Welcome back to Therapeutics. In this cardiovascular block, we're going to focus on the antithrombotics. And in the first of these two antithrombotic presentations, we'll focus on the drugs themselves and some idiosyncrasies with each of the classes of drugs. We put the antithrombotics discussion in the cardiovascular block because many of the indications for antithrombotics are particularly related to cardiovascular disease. But we also will see that the antithrombotics cross over into other areas. So, for example, as it relates to more vascular than cardiac events, for example, a deep vein thrombosis, pulmonary embolism, or other conditions where there's a risk for CVA. The biggest one is atrial fibrillation, but that also crosses over into neurology and stroke. And then for DVT prophylaxis, which is primarily in surgery, you'll come back and see us talk about these agents in other settings. The other issue to think about with the antithrombotics is that as a group, they are fairly narrow therapeutic index drugs, and so we need to be really vigilant in our assessment of the risk and benefit, the risk for bleeding, the benefit of avoiding a thromboembolic event or managing an acute thromboembolic event. All these sort of up the ante when we talk about antithrombotics. There's a lot of detail in this presentation and the next guideline presentation. And while it can initially feel overwhelming, I think it's critical that as a student who's first exposed to this content, that you get the big picture as well as some of the details that we'll talk about that illustrate general principles of use. But then as we talk about these contexts or individual situations with each of these drugs, so we get a little more specific about them, be thinking about the general risks of what's the bleeding risk for this patient, what is the benefit of using an antithrombotic in this patient, what are the comorbidities that affect that, what are other conditions or reliability of the patient that influence your choice of using a narrow therapeutic index drug in that patient. So our discussion will talk about differentiating the antiplatelets, the anticoagulants, and the fibrinolytics in this first block. And we'll also begin to talk about how we will think about using those drugs in practice. The second presentation will spend more time looking at some of the practice guidelines. The latest practice guidelines that are nationally or internationally accepted for use of antithrombotics really fall into two categories. In 2016 are the latest guidelines for the antithrombotics as they relate to treating deep vein thrombosis, pulmonary embolism, and other thrombotic events. And then in 2018, which we'll deal with separately, are the guidelines in the management of anticoagulation in patients with atrial fibrillation. And this subsection of guidelines was really updated in the advent of the novel anticoagulant agents, oral agents that have sort of come to bear over the last 5 or 6 years or so. So we'll talk about that in the second block. So our focus here, when we talk about antithrombotic drugs, we really separate this into three specific categories. The antiplatelets, the anticoagulants, and the fibrinolytics. And we'll talk a bit about each of these more specifically in just a little bit. And this should dovetail with the more specific content you're receiving in this block about more detailed background on each of these agents. And remember, our focus here primarily is to give you a little clinical sense of, okay, what is the person in practice going to do with this information? How do we use this information to make clinical decisions in patient care? So one of the things we need to consider is what the nature of a thrombotic event is. So one of the things, for example, is if a patient has a thrombus in the atrial system, typically those are associated with atherosclerotic plaques, sometimes in conjunction with a patient who has concurrent hypertension and or has turbulent blood flow around an epithelial lining of blood vessels or maybe in the heart itself, for example. For risk factors for various thrombotic events, we typically focus on the classic issues that will contribute to thrombosis in patients. And I'm assuming this has been covered or will be covered in the hematology block in more depth than what we're going to do here, so this should be pretty much a review. But when we think about who is a patient who's going to be at risk for a thrombotic event, be it a venous or an arterial thrombus, we worry about really three basic factors. One, we worry about stasis, immobilization. This is a big issue, for example, for the development of deep vein thrombosis in bedridden patients in hospital. This is particularly true, for example, in an orthopedic patient who's had a hip or even more importantly, a knee surgery, knee replacement surgery or hip replacement surgery, for which there's a lot of pain and even moving around. The patient may not want to move around, and that immobility significantly increases the risk for a clot. And that's also going to be true in clinical practice, particularly in orthopedic surgery, for just beyond the immediate hospital stay, but will prolong into weeks after the surgery has been completed. And we'll talk a bit more about that later. A second concern is where there's been localized trauma, and localized trauma may initiate the clotting cascade and lead to either an arterial and or a venous thrombic event. And the third issue are situations that are hypercoagulable states. And we think of most often, at least when I think of in clinical practice, a patient who has a hypercoagulable state. I often think of certain cancers that predispose patients to hypercoagulable states. And so you'll find, for example, that we are pretty aggressive about treating or preventing clot formation in a patient who both has a cancer risk and or has a high risk or a pre-existing thromboembolic event. So let's look at the basic factors that involve in blood coagulation. This hopefully is a review from what you remember from anatomy and physiology, as well as other things you may have heard already in the hematology block. But the agents we're going to use are going to be either drugs that affect platelet aggregation primarily, or drugs that interfere with the clotting cascade of some point, the anticoagulants, or to a much lesser extent, but in more serious conditions, might consider the use of fibrinolytic, or the older term a thrombolytic, which would actually dissolve an existing clot. But we'll limit our discussion with those fibrinolytics because their use, particularly at full doses, is limited to cases where the risk for not treating the clot aggressively is outweighed by the much higher bleeding risk associated with the use of fibrinolytic therapy. So as you think about the formation of a hemostatic plug, this is a very simplistic version of the formation of a hemostatic plug. But when exposed collagen is noted in a blood vessel, for example, that will release a process, among other things, thromboxane A gets released, that ultimately triggers the recruitment of platelets to that site to form an initial platelet plug. And ultimately, that platelet plug triggers the clotting cascade, the activation of clotting factors, ultimately to intermesh fibrin strands amid those platelets to form fully a clot. So when we look at our therapy, we're going to see that there are a couple of different places where we can interfere with this clotting cascade, or more specifically, the development of a clot. We can do that before the clotting cascade gets activated by interfering with platelets. We can interfere with the clotting cascade itself. Those would be anticoagulants. Or for an existing clot, we could look to dissolve that clot, and that would be with a fibrinolytic. So let's first look at the antiplatelets. And one of the mechanisms of antiplatelets, not the only one, but one of them is the interference with thromboxane A. That's, for example, how aspirin may work. But there are other mechanisms to interfere with this as well. Thromboxane A is not the only mechanism involved in antiplatelet function. The antiplatelets, we consider any drug by any mechanism that interferes with platelet aggregation, at least classically, as an antiplatelet. And we're concerned about when we use drugs that are antiplatelet or anticoagulant, is that when a patient then is at risk for trauma, or they have pre-existing categories for a bleed of some sort, interfering with either platelets or platelet function and or coagulation pathway can significantly increase the risk for bleeding, particularly for patients who've had trauma. So always when we consider anything of use of these agents, antiplatelets, anticoagulants, particularly fibrinolytics, we're always weighing the benefit of preventing or reducing an existing clot size over time with these agents, the benefit of having that therapeutic benefit of using these agents against the ongoing risk for bleeding. And even drugs as simple as low-dose aspirin as an antiplatelet do increase the risk for bleeding, particularly in older patients or patients who have pre-existing bleeding conditions. So all of that gets weighed as the risk and the benefit. We'll also find that sometimes we'll use antiplatelets both as a prophylactic therapy, and we'll talk a bit more about that, particularly with some, always there's controversy about using these agents and where they fit, but even as late as mid-September 2018, there's new published data to suggest that our use of antiplatelets in older patients, which we thought was beneficial, may not be so. And we'll talk about that in a couple of minutes. But keep in mind with all these agents, there's always a risk, and we're going to weigh that risk against their benefit. We will find, however, that the antiplatelets most often are used for their cardiovascular benefit, particularly in patients who've had an MI or a coronary event, or who have had a thromboembolic CVA, cerebral vascular accident. The mechanisms of how antiplatelets work vary. We have interference via thromboxane A and an irreversible inhibitor of cyclooxygenase, that's aspirin. We have agents that work on ADP receptors that are antiplatelets in that regard. And the most common three agents in practice these days are clopidogrel or Plavix, Pressugil or Effient, or Trategrelor or Brilinta. And each of these three antiplatelets are used pretty commonly in practice, particularly in folks who have had a coronary event, particularly in patients who've had a coronary event with a stent placement. More on that in cardiology later in the year, but I think it's important to introduce that concept of where they fit this far early on. We also have a couple of other agents that you will see less often used in practice, and the remaining things on this slide less commonly seen. We have a phosphodiesterase inhibitor, Plental, that's sometimes used as a platelet inhibitor, particularly for folks who have peripheral vascular disease, although in clinical practice we don't see that used much anymore. We have pretty potent intravenously administered agents that interfere with glycoprotein 2B3A receptors on the surface of platelets. These include abciximab, eptifibatide, and tirofiban, and these are IV administered meds that are typically limited to patients who are being transferred, for example, from a rural hospital to a hospital with a cardiac cath lab when they have a inability of getting an immediate cardiac catheterization and they have an evolving cardiac status that merits getting them to the cath lab right away. We also have adenosine receptor inhibitor, dipyridamole or persantine, that was more commonly used a decade ago for CVA patients or patients with transient ischemic attacks in neurology. We don't really see that agent used quite as much as we used to. And then there's finally a newer agent that's I'll tell you personally, have not seen used in clinical practice in our setting is tiratrubban, and an agent I have very little familiarity with. Let's first talk about aspirin. Aspirin is a classic antiplatelet agent. Now, we think of also aspirin as an anti-inflammatory and an analgesic, and it can be used for that purpose. But aspirin as an agent has probably a higher risk for GI bleeding than some of the other anti-inflammatory agents do, and as such, we don't really see aspirin used all that often for analgesia or pain, and limit its use primarily to cardiovascular risk patients who are at risk or have a high risk for an MI or a cerebrovascular accident. Aspirin works by blocking thromboxane A2 synthesis from arachidonic acid, working therefore to impact prostaglandins that may trigger platelet aggregation. It's indicated acutely in folks who have chest pain. We give basically folks with chest pain where we're ruling out an active myocardial infarction. We'll give them aspirin initially, and we'll also give it imminently for a patient who has a CVA if we're pretty sure that CVA is not hemorrhagic in nature. But when would we never use aspirin? Whenever there's a known bleeding, a cerebral bleed, a gastrointestinal bleed, or some other hypersensitivity to aspirin. Aspirin on occasion causes some risks for hypersensitive reactions, including bronchospasm in a few patients, particularly patients who have nasal polyps and or have concurrent asthma. So we weigh the risk and the benefit of aspirin in all of these patients. We'll get into more depth later in the year when we talk in cardiovascular medicine about aspirin's role in cardiovascular medicine, and also in neurology when we talk about its role for patients who had a cerebrovascular accident. Some of the adverse effects for aspirin, mild ones include heartburn, nausea, vomiting, but the real serious ones we worry about are bleeding. Bleeding really from any site, GI bleeding probably the most common, but you could also have particularly a patient who has had a head trauma of some sort. We worry about a cerebrovascular bleeding. We also worry about patients with aspirin with prolonged bleeding. So typically because aspirin has its antiplatelet effect for up to 5 days or so, we recommend that we stop aspirin typically 5 to 7 days before elective surgery. We're also generally trying to avoid aspirin in patients who are allergic to other nonsteroidal anti-inflammatory agents, particularly other salicylate-specific aspirin like NSAIDs. Although, truth be told, true allergies to NSAIDs in the nature of a hypersensitivity reaction involving immunoglobulins or a true allergic reaction are not all that common. Aspirin is available primarily orally or as a rectal suppository. It's available in low 80 milligram or 81 milligram strengths. There is 160 milligram strength that's not commonly used, and there's a more common 325 milligram strength as well. And typically it's dosed in either 81, 160, or 325 milligrams. If you want an immediate effect, we typically will give the immediate release or chewable aspirin formulation. If you are looking at somebody getting a drug chronically, you can use either the enteric-coated or the immediate release aspirin. At the onset of aspirin within 30 minutes, typically for a patient with chest pain and rule out MI, we want them to chew that tablet and get it into the body as quickly as possible. But the ongoing effect of aspirin can be prolonged up to 5 to 7 days as far as an antiplatelet goes. Its safety in pregnancy, the older terminology would have considered it a category C or D drug. There is a limited role for aspirin use in pregnancy. I'll defer that limited spectrum role to when we get to obstetrics, but for the most part, usually our recommendation in pregnancy is to avoid aspirin when we can. And we also don't use it in pediatric patients because of the risk for Rye syndrome or liver injury associated with aspirin in a patient who has a concurrent viral infection, and that syndrome is known as Rye syndrome. What's a little confusing sometimes for clinicians who are new to practice is they'll often hear people refer to the 81 milligram dose of aspirin as quote-unquote baby aspirin, or older patients may refer to the 81 milligram low-dose aspirin as a quote-unquote baby aspirin. And in clinical practice, 30 years ago, before we really knew about Rye syndrome risk, aspirin was commonly used in low dosage in a chewable form for children, and so it was known at that point as baby aspirin, which we do not give anymore. There are some of the other platelet inhibitors in this section. So let's spend a moment looking at this slide. And while there's a lot of detail on this slide, and we don't expect you to recognize the detail that's presented in this slide, primarily one of the reasons we included here is because there are a couple of elements in this slide that compare these agents that are pertinent for our discussion here. More of the details about the dosing or the regimens that are used for each of these drugs, uh, we'll come back and talk about in the cardiovascular block. And the context of the dosing here is primarily for a patient who is undergoing stent and has an acute coronary event. So more about that later in the year. But one of the things that this slide does differentiate is that clopidogrel really works a little differently and is metabolized differently compared to the other two agents on this slide. And the big issue is that if you look in the metabolism section, that clopidogrel or Plavix is a prodrug, meaning that Plavix itself, as it's administered, as it's taken in the body orally, is not pharmacologically active. It has to be converted via the cytochrome P450 enzyme 2C19 into its active compound that is then effective as an antiplatelet. So we get a little worried about patients who may have a genetic predisposition to not make or to make a variant amount of 2C19, and that might reflect maybe 3 out of 100 patients in the North American population. And those patients, if they are taking another drug that affects the metabolism via the 2C19, for example, some of the proton pump inhibitors like omeprazole or Prilosec can do that, then we have to worry about that interaction, and particularly in those folks who are genetically predisposed to not be able to convert the prodrug to its active drug, meaning that 3% of the population who took Plavix and concurrently took Prilosec, a very common over-the-counter agent for an acid, those patients, the antiplatelet action wouldn't work. And so the way we can approach this is either avoid the proton pump inhibitor entirely or any other interacting drugs with Plavix, so we know every patient's there, or perhaps get the genetic testing. I'll tell you, truth be told, we are currently, at least in the practice areas I've been clinically, we don't do the genetic testing for patients routinely. And if it's done, it's becoming more common for patients to get that, for example, done on their own with their own genetic testing from all the companies that are now doing it. We still then don't know how to interpret or use that data in a clinical setting to know at what point does that genetic information help us with a decision. That may change in the next 5 to 10 years, but currently, if you've got a patient who needs to be on a proton pump inhibitor, particularly Prilosec, with Plavix, our recommendation is instead either avoid the proton pump inhibitor or use one of the other two drugs in this class, either Effient or Brilinta. The concern with Effient, and particularly Brilinta, is that the risks for bleeding may be more critical or maybe more higher, but the efficacy as an antiplatelet may be a little bit better too. So there's a lot of debate about that. But what you'll find once we get to cardiovascular medicine is that different cardiologists may pick different agents depending on what their experience is and also what their impression of the bleeding risk for that patient is. So we'll come back and talk more about these agents either in neurology, where these agents are used, or in cardiovascular medicine, where they're used. But these agents are only used in patients who've had an existing MI, usually with a stent, or an existing cerebrovascular accident. They're not commonly used for patients who might be at risk for an MI or a CVA, but haven't had one yet. Here's another chart that sort of looks at some more of the data that's said here, and typically other things to think about in comparison to these agents, among other things, is that we will look at, there's some information about the drug interactions we alluded to, also how long they're effective as an antiplatelet, how much time do you hold these drugs before surgery, and you can see, depending on the agent, it's 5 to 7 days, pretty similar to what we saw with aspirin. Another agent less commonly used is dipyridamole, either alone or in conjunction with aspirin. It's an older agent that has some antiplatelet properties. It's sometimes used in patients who've had a CVA to prevent a future CVA, but probably not as commonly used now as some of the agents we've already talked about. The 2B3A inhibitors, the glycoprotein 2B3A inhibitors, are all intravenous agents that are monoclonal antibodies, fairly expensive agents that block platelet aggregation pretty effectively and almost immediately. And they're really used as adjuncts in a patient with an existing coronary event when they're undergoing angioplasty in the cardiac cath lab, or maybe in conjunction with a thrombolytic agent or fibrinolytic agent, usually in the purview of a cardiologist. And so these are not agents that many clinicians will see in primary practice, but we allude to them. The issue is, of all of the antiplatelets, these are probably going to be the highest risk for bleed, and they're expensive to use, but we'll see them used in high-risk situations where aggressive antiplatelet therapy is required. The contraindications for using a 2B3A inhibitor are patients who have active bleeding. And think of all the things. Basically, some of these are the same contraindications you might have for some of the earlier antiplatelets we had, but the risks here for these 2B3 inhibitors are so much greater for evolving bleeding. So if somebody's had a significant bleed or hemorrhage recently, they've had a CVA in the last couple of years, particularly if it's hemorrhagic CVA, cerebral vascular accident. More on that in neurology later in the year. They've had bleeding disorders. They have low platelets. They've had major surgery in the last few weeks. They've had some kind of intracranial process, an atriovenous malformation, an aneurysm, an intracranial tumor. They've had severe hypertension. All of those risks increase risk for cerebral bleed, and giving antiplatelet in that circumstance really increases their risk for cerebral bleed. So we're careful about that, or anybody who's had a hypersensitivity. Adverse effects are even more so than with the other antiplatelets, bleeding from any source. You could also see thrombocytopenia. There are some interactions you need to be aware of, particularly interactions that could affect bleeding risks for patients. It's given intravenously. These are only the 2B3 inhibitors, 2B3A inhibitors, are really only going to be used by the cardiologist or under the direction of the cardiologist in a very limited role for a short period of time. The duration of action varies on the agent, and we sort of alluded to all of these issues already. So as far as the antiplatelets go, we'll put in context and talk more about this both later in this slide presentation very quickly about where they fit. But there's also, I thought this was important to include this because at least as of September 2018, this is a really kind of a hot button issue. We kind of debate what's the role of giving antiplatelet for a patient who may be at risk for a heart attack or a stroke or have colorectal cancer. And in 2016, sort of a consensus statement by a well-recognized organization, the U.S. Preventative Services Task Force, looked at a summary of all the data that was published up to that point in time and recommended that for patients age 50 to 59 years of age, if their coronary risk for a cerebrovascular event was greater than 10% over the next 10 years, and we'll talk more in cardiovascular medicine about how we gauge that. You know, were they smokers? Do they have hypertension? Do they have diabetes? Do they have pre-existing coronary events? All of those go into a risk stratification of risks who are at risk for a future event, and that more of that will come later. But the recommendation as of April 2016 for patients 50 to 59 years of age is if you had this increased risk, we recommended giving a low-dose aspirin every day. And similarly, if you're the age 60 to 69, we recommend that pretty much as well if your risk factor is, again, greater than 10%. But the evidence for the 60 to 69 group is not quite as strong as the evidence for the 50 to 59 year group. What they recommended in April of 2016 also was that patients younger than 50 or older than 70, the data was not yet strong enough for us to recommend either routine or avoiding aspirin in either of these two populations. Again, these are all patients who have not had an MI, they've not had a stroke, but they may be at risk for that. That pretty much changed. As of the time I'm doing this audio presentation, that all changed yesterday. And this is sort of a lesson for all of us in practice, is that things can change dramatically. And sort of what hit the news yesterday was that daily aspirin may be harmful for older adults, particularly over the age of 70, if you don't already have a stroke or have had a heart attack or a known coronary event, the data for how these drugs work and whether they are beneficial compared to their risk for bleeding, this study suggested it was not recommended. And so this is based on really a series of 3 studies published in the New England Journal on September 16th of 2018. This was the pivotal one. The 2 related studies in the same journal issue sort of substantiated some of the findings that are listed in this larger study. This was a pretty robust or large study that looked at almost 20,000 patients, both in Australia and the United States. And they looked at patients over the age of 70. And they looked at, they didn't have an existing coronary event, they didn't have an existing stroke, but we were looking at, for this population, did it make sense to give them once a day low-dose aspirin to prevent a future stroke or a future cancer risk. And lo and behold, what they found in this over 70 population was, in fact, was there no benefit in the patients who took aspirin as far as their cardiovascular benefit. What was worse for that patients who did take aspirin is that their cancer risk appeared to be actually higher, which was quite surprising, and their hemorrhage risk was also higher. And so this single study, which is fairly large, is probably going to pretty quickly turn into the practice recommendation of not starting patients, particularly over the age of 70, on low-dose aspirin to prevent these kind of events. And so while this is not expected that I'm spending a lot of time talking about this, what's important to sort of walk away from with this is to recognize that our evolving understanding of how these drugs work in clinical practice will be guided by such large studies as this, and you'll see that the recommendations we make at one point in time may evolve or change over time. And also this gives you a perspective of how we use aspirin. So right now we use aspirin low dose in patients who've had a heart attack, who've had a stroke, yes, and maybe in patients who might be at high risk for heart attack and stroke between the age of 50 and 70. And this study may even have people be a little more skeptical about that. But we'll talk more about how we quantify that risk for coronary events later on in cardiovascular medicine. Okay, now let's switch gears a bit and talk about anticoagulants. Anticoagulants interfere with the next step in clot formation after the platelet plug has been developed. And this is all the factors that contribute in this cascade, leading ultimately to fibrin strands being intermeshed among the platelets to form the clot. And our hope is that you have had some background already as you listen to this, either in basic anatomy and physiology or in other components in your curriculum, to look at the coagulation pathway. In the coagulation pathway, things that can ultimately trigger fibrin to being developed can be done by sort of the old intrinsic pathway or the extrinsic pathway. And this has kind of been a way that people have looked at this over the last 30 years or more. An intrinsic pathway also used to be determined as the contact activation, or the extrinsic pathway by tissue injury. But ultimately, there are multiple factors, including the clotting factors, that sort of trigger to one another, ultimately leading to factor 10, ultimately factor 5, prothrombin, triggering thrombin, leading fibrinogen to form fibrin. And each of these cascades is sort of work sort of in conjunction in the presence of calcium or other substances, sort of to lead to the next step, ultimately leading to the fibrin formation and the clot formation. The issue we think about in practice is that we can interfere with one or more of these steps, and when we give an agent that interferes with one or more of these steps, that can decrease the ability of coagulation to happen, and those anticoagulants could be used therapeutically to either lower the risk for a new clot or to prevent an existing clot from getting any larger, while the body naturally makes that clot go away over time by its natural ability to decay an existing clot. And so that's basically what the role of the anticoagulants are. As we look at the coagulation pathway, we keep in mind that there are 4 of these clotting factors that require the presence of vitamin K to be effective. And so if we interfere with vitamin K, and we do that with an older drug called warfarin or Coumadin, by interfering with vitamin K, we interfere with these clotting factors, the synthesis of these clotting factors. And so after we give a dose of a drug like Coumadin or warfarin, we'll see that in the next few days, the amount of these clotting factors goes down, and we see more anticoagulation occurring, more difficulty in actually forming a new clot. So when we think of warfarin, for example, and we'll talk about this in a little bit, we'll think about warfarin interfering with these 4 clotting factors and the synthesis of these clotting factors. So that basically means that if your body has those clotting factors in you right now, or you give somebody fresh frozen plasma, which has those clotting factors in it, or you give them one of the new factor derivatives to a patient, all of those will immediately give someone new clotting factors, and all warfarin does is prevent the synthesis of your body to make future clotting factors, not interfere with those clotting factors if you're giving them intravenously. So let's look at some of the anticoagulant agents, and these are agents that are designed to prevent primarily an intravascular thrombotic event by decreasing blood coagulability. They're not going to dissolve an existing clot, although they create the environment that prevents a clot from getting larger if it's already there, and allows the body to, on its own mechanisms, to begin to decay some of that clot by its natural process. So you want to be aware of that. Like with the antiplatelets, the biggest risk for the anticoagulants is bleeding, hemorrhage from any site. And for the anticoagulants, that risk for bleeding, particularly when we use higher doses of these anticoagulants, the risk for bleeding is greater, probably than, as a rule, most of the antiplatelets are. And so we're always thinking, whenever we use an anticoagulant, weighing the benefit of avoiding a future clot or the benefit of treating a clot that already exists from getting bigger against the risk for bleeding. And all of that is a case-by-case evaluation. So what are some of the tools we have for giving an anticoagulant? Well, classically, we see those agents that can be given parenterally. We have the heparins and heparin-like drugs. Heparin, we'll talk about in a few minutes, both unfractionated heparin and low molecular weight heparin. We'll talk and differentiate those groups in a bit. Or we also have an heparin-like drug, Arixtra, which also has its unique kind of role when we use that. We also have the vitamin K antagonists, for which in the United States the only one we have in the U.S. is warfarin or Coumadin. There comes a couple of different brand names in addition to Coumadin for warfarin now. And for the last 3 decades, Coumadin has been the standard oral anticoagulant we've had. It really hasn't been until the last 5 to 8 years that we've had some alternatives to oral Coumadin for a number of patients. Those include the oral direct thrombin inhibitor, dabigatran or Pradaxa, or more commonly now we see even replacing dabigatran or Pradaxa in most clinicians' minds are the direct factor 10A inhibitors that are given orally, and we'll talk more about those in a bit. The novel or direct-acting agents are rivaroxaban or Xarelto, apixaban or Eliquis are the 2 big ones. And in fact, if you ever turn on television with advertising, you can't help but hear an ad for one of these 2 agents sometime in an evening's watching of television. So let's talk through some of these agents and where they fit. So let's first look at unfractionated heparin. Unfractionated heparin has been on the market for a long time. It's actually derived either from an animal source, either from a pork, pig, or a cow. It's either referred to as porcine, pig, or cow, bovine sourced heparin. And what they do is they work to potentiate the activity of antithrombin 3, and we will measure its effect in the degree of anticoagulation primarily by the test of an activated partial thromboplastin time. Although in some settings, include the setting I work at now, we've largely replaced the APTT as our means to evaluate the degree of anticoagulation for a patient on IV heparin with the anti-10A activity, the degree of 10A activity that a patient may have. Either one tells us how anticoagulated a patient is. And I want you to sort of reiterate again the risk for bleeding with these agents. These agents, particularly the anticoagulants, are all considered a low therapeutic index drug, meaning these are drugs for which the margin of safety is fairly narrow, meaning that if we gave the very same dose to 10 patients, 2 patients may have very serious life-threatening events. 2 patients may have exactly what we want to see happen, or 5 or 6 patients exactly what we want to see happen, and an additional 2 patients may have a subtherapeutic response, not adequately work. The drug may not adequately work. So we are careful when we use the anticoagulants to make sure we have the right dose, that the patient gets monitored carefully, because the risk for bleeding is serious, and the risk for not giving enough drug to achieve the patient who has a high risk with a clot is also serious. The outcomes on either end of not getting the dose right is pivotal. Our indications for unfractionated heparin, giving it primarily IV, we can also give lower dose subcutaneously, are for folks who have existing clots or at high risk for clots. Those include patients with coronary events like unstable angina, folks who've had a catheterization procedure, folks who have had other kind of thromboembolic events like a deep vein thrombosis or a pulmonary embolism. Also folks who have had a thromboembolic stroke or CVA, not a true hemorrhage stroke, but a clot-based stroke. More about that specificity in cardiovascular and neurology later in the year. There's a few issues as far as dosing that's listed here. I encourage you to let that sort of fall over your eyes. But just keep in mind that when we're giving full dose heparin for a coronary event, an active coronary event or active deep vein thrombosis, not prophylaxis of preventing one in a patient who is in a hospital bed and not moving, but somebody who's actually had a thrombus of some kind, we give big dose IV heparin, and we monitor it carefully with this set of tests. Usually every 6 hours we'll measure the APTT and or the anti-10A activity in the blood and titrate the heparin IV drip according to the result of that number. So we pay really close attention to that. This slide pretty much describes the effect of heparin versus no heparin on active clotting factors 2, 9, 10, 12, and 13. Ultimately, we see with heparin, we see a more rapid inactivation than without heparin. So unfractionated heparin, and what we mean by unfractionated heparin is heparin itself is a large molecular weight substance, very large molecular weight, big protein. And our concerns with this protein include both the risk for immune-related thrombocytopenia, and we'll talk more about that in a little bit with heparin-induced thrombocytopenia. We also worry about bleeding from any site with heparin, and that's going to be a real concern for us. So bleeding and severe thrombocytopenia that already is in place would be considered a contraindication for adding heparin to that therapy. And for patients who are on heparin, we watch for future bleeding or future thrombocytopenia. There is a reversal agent for unfractionated heparin, which is protamine, but in clinical practice, we probably don't really use it all that much because heparin itself has a relatively short half-life. You turn the heparin drip off, and lo and behold, in 4 to 6 hours, you kind of expect most of the effect of heparin to be gone. We alluded to the fact that there is an immune-based reaction that happens in a small subset of patients who are on heparin that ultimately results in thrombocytopenia. And here we have antibodies that complex with platelet factor 4 and heparin. And the folks who are at highest risk for heparin-induced thrombocytopenia, sometimes referred to as HITS, H-I-T-S, are patients who are on unfractionated heparin. It can happen with the low molecular weight heparins we'll talk about in a minute, but it is less likely to happen than with the larger molecular weight unfractionated heparin. Basically, what we see the risk here is that the thrombocytopenia can also involve with thrombosis at the same time, which sounds almost counterintuitive, but it's basically how this clotting cascade works. And so a patient who has true heparin-induced thrombocytopenia, we have to both stop the heparin so it doesn't get worse, and we also have to give them a different anticoagulant, and that could be argatroban, or it could be maybe, if it's a low enough risk, maybe a Rixtra, which is different enough from heparin in most patients not to contribute to further thrombocytopenia. But there are a number of different ways you can assess the risk for HITS, and probably the most common thing that we see in clinical practice right now and for the last decade or so is the 4T tool that's listed here, where you get patient points for whether or not a patient has a risk for thrombocytopenia. So this is used in assessing a patient's risk, and just recognize this. Usually when we worry about heparin-induced thrombocytopenia, typically is a patient who has a big drop in platelets after we start heparin in the first couple of days or so. So we want to really be aware of any change in platelet function. So as we're starting patients on heparin, we're continuing on heparin, particularly full-dose heparin. We want to look at their H&H, hemoglobin hematocrit for bleeding risk, and we also want to look at their platelets as it's a risk for heparin-induced thrombocytopenia. The low molecular weight heparins are alternatives to the larger molecular weight heparins, the unfractionated heparins that are available. And the low molecular weight heparins have been around for more than a decade. These are still, by default, pretty large chemicals as far as drugs go. They're still large, but they're fractionated in such a way they're about a third of the molecular weight of the unfractionated heparin. And they work in very similar ways, but they're pretty, they're usually, most of them have a stronger affinity for 10A than you would see with standard unfractionated heparin. There are lower doses that are used for prophylaxis and higher doses that are used for therapeutic treatments for folks who have a clot. Probably the only agent that in clinical practice, at least in New England, that I've seen is Lovenox or enoxaparin. The other low molecular weight heparins have largely fallen off the map because Lovenox or enoxaparin has been studied probably the most, is most widely used, and has the broadest of indications for their use. When you're looking at a low molecular weight heparin, you still worry about bleeding risk. Some degree, you're still looking at heparin-induced thrombocytopenia, although that risk is probably considerably lower than it is with unfractionated heparin. In addition, you want to be very careful in dosing low molecular weight heparin about, is your goal to prevent a clot, to prevent a DVT? And in that circumstance, for example, a hospitalized immobile patient, you're trying to prevent a DVT, we look at low dose. We look at a 30 or 40 milligrams subcutaneously once or maybe twice a day, depending on its indication for use. And we don't usually need to monitor an APTT or anything like that, or a 10A level. Or is our treatment a high dose, usually a milligram per kilogram subcutaneously every 12 hours for a patient who has a DVT or a pulmonary embolism? So you want to be clear on what the goal of therapy is. Is it prophylaxis, where we use a low dose, or is it therapeutic, where we want to use a high dose? And that's a very important differentiation that over time, and we'll reinforce this later in the year, but it's a big deal about what dose we're using for the low molecular weight heparins. This is a comparison of the heparin products, and don't get too caught up in the detail of dosing and the like here, but this gives you an idea about the different regimens that are used for heparin and for enoxaparin. Those are the two I'd really focus on here, and you can see there are different regimens for different indications. There are also a few other drugs. Here's one that is a heparin-like drug. All right, let's look at some of the direct thrombin inhibitors. These agents typically work directly on thrombin itself or factor 2. And orally, we have an oral agent, the dabigatran. We'll talk about that in a bit, as well as a couple of parenteral agents for which some of these are widely used and more widely used in practice, but none of them, I'll tell you, are widely used. Really, the only one I think I've seen, or the two I've seen used, or three I've seen used, depending on where your practice setting is. If you're working in a coronary tertiary care facility, you're likely to see more use of ergatroban and lepirudin. Perhaps you might see bivalirudin as well, or even herudin. But if you're working in ambulatory care or you're working in a smaller community hospital, these agents, particularly the parenteral ones, are largely limited to patients who have heparin-induced thrombocytopenia because they're non-heparin alternatives to anticoagulation where we need an anticoagulant. So bivalirudin or Angiomax has been used in some of the earlier studies for patients with MIs a decade ago or so, and there was some data about whether it was more effective than heparin when folks who were undergoing reperfusion or occlusion studies and angio in the cath lab. Interestingly, here's a drug that's derived from the saliva of leeches, and so that might kind of make you think, gee, really? But yes, really. And it's used as an anticoagulant in conjunction with folks who are going through cath procedures, cardiac cath procedures. Ergatroban, at least in my limited experience, it's a direct thrombin inhibitor that is really only used in patients who have heparin-induced thrombocytopenia. And depending on how much heparin is used and what the risk is for a patient, that, you know, if you work in acute care, on occasion you may in fact see this drug used. And I'm not going to get into the specifics about this agent, but know that it's a kind of an alternative agent we occasionally use for patients with heparin-induced thrombocytopenia. Let's look now at some of the oral agents, and these are pretty widely used in practice. And first, look at the standard agent we've used for decades is warfarin or Coumadin. And warfarin or Coumadin still is used. It's still a first-line therapy as an oral anticoagulant for certain conditions where the replacement, the newer novel oral anticoagulants have not yet been tested or proven. And that includes, for example, a patient who has had a mechanical cardiac valve replacement. And so that's going to be an issue or a thing that we think about in clinical practice. So warfarin, as we alluded to a bit earlier, is a vitamin K antagonist. It's indicated for the prevention of a thromboembolic event in patients who've had a deep vein thrombosis, patients who've had a pulmonary embolism, and patients who are at high risk for an embolic event, like a patient who has a prosthetic heart valve, particularly a mechanical heart valve, or who have atrial fibrillation, or have had stroke or other hypercoagulable states. Until the last 4 or 5 years, it was even used for hypercoagulable states for patients who had cancers, but there's probably stronger data that the low molecular weight heparins like Lovenox or enoxaparin have better data for patients who have recurrent thromboembolic events who are hypercoagulable, particularly related to cancers. So how these drugs work. They prevent the formation of new vitamin K-dependent clotting factors 2, 7, 9, and 10. Because they prevent new clotting factors but don't do anything to the clotting factors that are there, it requires the body to decay when we stop making new ones, but the ones that are already there, they have to naturally decay before we see an anticoagulant effect. And so when we give warfarin, we have to keep in mind that it might be a couple of days, usually it's a couple of days before we see its anticoagulant effect. We also have to recognize a couple of things that are a little unique to vitamin K, that we have a lot of genetic variation in vitamin K receptors, as well as genetic variation in the metabolism of vitamin K. There is warfarin exists really as what's called a racemic mixture. You may or may not remember this from chemistry, but warfarin, when you get it as a tablet form, is both a a right-handed and left-handed version, sort of two mirror images of the same chemical compound and a 50-50 ratio, but it's only the S isomer, one of those two, that is particularly potent at receptors where warfarin works, and the R isomer is not nearly as effective. And so there's sometimes some genetic variability that might impact that, as well as some interactions with a number of drugs. So how does warfarin, what are some of the key kinetic issues for warfarin? Well, it's absorbed pretty rapidly. It's extensively absorbed by the gut. And it hangs around itself in the bloodstream for a day and a half or 2 days or so. It's highly bound to proteins in the blood, plasma proteins like albumin. But the difficulty we have to think about is that not only you have to worry about the half-life of warfarin, you have to worry about the half-life of the clotting factors that are being interfered with their synthesis. Because, okay, let's say you fully interfered with a lot of the synthesis for factors 2, 7, 9, and 10, you won't begin to see an anticoagulant effect for a couple of days until the existing clotting factors 2, 7, 9, and 10 have begun to decay. So this graphic sort of displays more or less what you'd expect to see for the decay of clotting factors over 24 to 48 hours. And you can see it's really 48 to 72 hours before the decay of the clotting factors is significant, which means that we don't expect to see a full anticoagulant effect for the dose of warfarin we give today until a couple of days from now. And this makes warfarin a pretty tricky drug to dose, use, and manage. And we'll come back and reinforce this in a couple of minutes. The test we use to determine the degree of anticoagulation with warfarin is called the INR, the International Normalized Ratio. It's a standardized version of the older prothrombin time, and it's standardized to what the reagent the lab uses. If you were to go back in time 20 years for patients on warfarin, we only use the prothrombin time. But the problem is that you could have the same blood sample from one patient, draw it in 5 different test tubes, send it to 5 different labs, and you would get a different prothrombin time depending on what reagents that lab used to do the test. And so by standardizing to the thromboplastin that the lab uses, we can then get a more meaningful number called the INR. And so an INR from lab A with the same sample should equal the same INR in lab B, C, and D. So it really is just a way to standardize an old test, that's all. So with patients on warfarin, we're always looking at the INR, and we want their INR to be in a particular range so that we've adequately anticoagulated them, so they won't form a clot or they won't extend the clot they've got, but not so much they're going to bleed. This is similar to with unfractionated heparin. We looked at the APTT, the activated partial thromboplastin time, or the anti-10A level, to make sure we gave enough heparin without too much, that they didn't form a clot, but they also had a lower risk for bleeding. So here are the goal INR ranges based on indication, and we'll talk more about this later in the year, but for most indications for Coumadin or warfarin, we're looking at the INR to be about 2.5. Will be considered 2 to 3 range acceptable for most patients. Occasionally, if they've had a bleeding episode, we may want it closer to 2. If they've had thromboembolic events while on low-dose warfarin, we may want it closer to 3. If they've had a mechanical prosthetic valve, particularly mechanical prosthetic mitral valve, we want that often to be at higher, around 3, with a range of 2.5 to 3.5. But keep in mind, even in this range is associated with adequate clot interference for most patients and lower risk for bleeding for most patients. But even in this range, patients can bleed, or patients conceivably could still have a clot. So on a case-by-case basis, this gives us a ballpark of what we shoot for, but is not absolute. The biggest adverse effect we worry about with warfarin or Coumadin is bleeding from any site. And that's a real concern. You worry about head trauma, any trauma, falls, bruising, any of that. Now that's true. Bruising, falls, head trauma, also a big concern with the antiplatelets, but even more so with the anticoagulants. and so you want to be really careful about that. There's a pretty rare thing called a hemorrhagic necrosis, bleeding into the skin. I'll tell you honestly, in clinical practice, not something I've seen very often. We also worry about other kinds of hemorrhages, including rarely something called an adrenal hemorrhage. But again, that's pretty rare. But bleeding from any site is the biggest concern for us. So when you're trying to assess is a patient, you're going to give patient warfarin or Coumadin. And the most common indication for patients on warfarin or Coumadin, particularly lifelong warfarin or Coumadin, is if they've had atrial fibrillation or AFib, a cardiac rhythm problem, which poses an increased risk for clots, emboli, and stroke. And so there is a standard, pretty easy risk stratification tool to estimate what a patient's risk in the next year might be for having a bleeding episode while on standard doses of warfarin or Coumadin. It's called the HAS-BLED score. But this could be pretty much, while it was developed for patients on warfarin or Coumadin, it could probably be extrapolated to other patients on the novel agents we'll talk about in a couple minutes as well. So in this study, and I'd encourage you to use on your handheld device in practice at your computer, there will be calculators for all kinds of things. You've probably already played with a few of them already, but there are risk estimations for bleeding risks. And what we'll talk about in cardiovascular medicine, we'll reintroduce this again, where we're going to look at two scores, for example, for a patient who has atrial fibrillation. We're going to look at their risk for a clot. We're going to also look at their risk for a bleed. And we weigh what's their clot risk versus what's their bleed risk to determine whether or not we're going to give them anticoagulation. So half of that equation is, if I put this older patient on warfarin or Coumadin, am I going to risk a bleed? So I'm going to add up all of this patient's history. Do they have uncontrolled hypertension? Do they have renal disease? Do they have liver disease? Have they had a stroke history? Have they had any major bleeding episodes or predispositions to bleeding? Is their INR, if they're on Coumadin, labile all over the map? Are they over 65? They have meds that could increase the risk for bleeding, like they're on concurrent aspirin or an antiplatelet or a nonsteroidal? Do they drink a lot of alcohol? For each of these elements, they get a point. And then it's an estimate, but for every point they accumulate, the risk for bleeding in the next year for a major bleed, GI, cerebrovascular, some other major bleed, goes up. And so that helps inform our decision making about whether or not this patient is a good candidate or not a candidate for anticoagulation. Now, as with everything else in medicine, you weigh that risk of bleeding with an anticoagulant against what benefit there is for anticoagulation. And when we get to cardiovascular medicine, particularly in atrial fibrillation, there's a similar scoring tool called the CHAD score, or variant of that in a sense looks at other factors that are going to be a risk for clots forming and a stroke forming for somebody on AFib if they weren't on anticoagulation. And they'll look at factors like age, pre-existing transient ischemic attacks or strokes, if they have hypertension, if they have heart failure, diabetes, vascular conditions and the like. And they'll also have a similar scoring tool that's going to help determine the degree to which they're at risk for a clot. And so we're weighing in practice their bleeding risk versus their clotting risk. And in practice, you will find that there are these scoring tools that are standardized and pretty well accepted. They're not perfect. We know there are limitations to them, but they help inform our decision about whether or not a patient is at risk for a bleed or a clot, for example, when we try to decide, does this patient get anticoagulation or not? With warfarin, we look at a number of interactions. There are major ones here. Whenever you start a patient on warfarin, you have to look at the drugs they're on to see the degree to which one of those drugs can cause a decrease or an increase in their INR while they're on Coumadin. These are major interactions that are critical to take account of. And so you will run a drug interaction check for every patient, particularly if they're on warfarin or Coumadin. So here are some drugs that decrease INR. Here are some drugs that increase INR. The big ones here are antibiotics like metronidazole, sulfamethoxazole, trimethoprim, also in cardiovascular medicine, an antiarrhythmic drug called amiodarone. But any other drugs on this list can cause the INR to go up and then the bleeding risk for that patient to go up, sometimes pretty dramatically. And we see this a lot in practice, not infrequently. And these interactions have made warfarin really one of the other things that have made warfarin a really difficult drug to manage. There are also food interactions with warfarin, particularly drugs and drug interactions with drugs that or foods that contain vitamin K. So vitamin K containing supplements or vitamin K containing foods, if they increase or decrease in the diet, that can be problematic. And sometimes we see seasonal variation depending on whether patients, have a backyard garden or go to the farmer's market in their season, sometimes of the year and not others. So if you see variation in foods that contain vitamin K, we look at standardizing that to the best of our ability. Lots of things we think of that have high content of vitamin K, particularly very high green leafy vegetables or green tea, also pretty high in vitamin K. So we want to keep the amount of vitamin K in a patient on warfarin pretty stable. So what is it that makes Coumadin or warfarin difficult drug to use? The delay in onset of effect. So the INR we get today reflects doses we gave a few days ago. The dose we give today won't have its effect for a couple days from now. We also see that there are different doses for different patients. It's genetic variation primarily that we see. There are lots of drug interactions that are a problem. There are food interactions, and there are generic forms. So any one of these variables in and of itself can be a problem. But keep in mind, all of the anticoagulants are narrow therapeutic index drugs. We need to keep that INR in that 2 to 3 range for most patients. If we go much above 3, we worry bleeds. If we go below 2, we worry clots. And any of these variables interprets or makes it difficult to do that. And so in practice, it's difficult to manage all of these things because you get a lot of balls in the air when you're trying to figure out what am I going to do for Coumadin dosing. And in a sense, if any of you have ever had the experience of driving in winter in anywhere where there's ice and snow, you recognize the risk for skidding. So if I've lived in New England most of my life or Minnesota, and I know that driving in winter, you learn pretty early not to oversteer because you can quickly go into a skid. Well, that's also true for patients on warfarin. When you look at dosing, you can run into big trouble when you find a patient who has actually their INR goes up or goes down, and you react too quickly with a response that actually can be counterproductive. So keeping in mind, when we give a patient on warfarin, we see a delay in its onset and a delay in so the dose we give of Coumadin today doesn't have effect for a couple of days, and the INR we're looking at today reflects what we did a couple of days ago. Here are a few simple cases I'm going to walk through quickly so you have an idea of how this comes and plays in practice. First patient, 81-year-old, and these are real patients, by the way, from practice from me maybe a decade ago, but we still use Coumadin, and these are kind of examples of why people don't like to use Coumadin. 81-year-old female with a new onset of AFib gets started on enoxaparin and warfarin. Now, why did we start her on enoxaparin plus warfarin at the same time? Because the INR didn't get therapeutic till day 4. You see that? Day 4, INR get up to 2.5 where we want it. So because we don't have her anticoagulated for the first 3 days and we want to prevent a clot, we need a fast-acting anticoagulant, and that might be Lovenox. Okay, so we gave her Lovenox. Once her INR got above 2, we could stop the Lovenox. But look what happened to her. Her INR was at 1.2. For someone who's not anticoagulated, we expect to be 1.0 to 1.2. That's normal. Okay. It jumped up to 1.7 in a day on day 3. By the time it got to day 4, she was already at 2.5. What we should have realized on day 4 is not only stop the Lovenox, we should have actually given her a lower dose of warfarin. Why is that? Because by day 4, she was shooting up pretty quickly. We probably should have stopped warfarin entirely on day 4 and then gave her maybe 2.5 milligrams on day 5 if an INR came back in line. But we overshot. She went up to 3, so they didn't give her any 3.4. So that's an increasing the risk for bleeding at that point. So we didn't give her any warfarin. And then we again waited maybe a little too long because as a delay, we gave her 5 milligrams on day 8 when she was subtherapeutic. We should have predicted that a little sooner for her. And not to give her 5 again, because we know if we keep her on 5 after day 9, she's going to run into trouble again. So she probably needs something in the range of 2.5 a day and sort of figure out what's what with her. But that's kind of the time course of sort of oversteering, stopping it entirely and not anticipating what the INR trend is. Here's the second case, a 91-year-old female on warfarin at home. She comes in with TIAs. Interestingly, she's a smoker, and she's on estrogen. Later on, we'll realize patients on estrogen, high risk for stroke and thromboembolic events. So we usually look at no estrogen for anybody who's got has a clot, and smoking even more problematic with estrogen for clot risk. So there's a lot of reasons why this woman shouldn't be a smoker and shouldn't be on estrogen. But hey, she got to 91. It's kind of hard to argue with her. So her INR is 1.4 at the start because she came in on Coumadin, but they held it because they wanted to rule out if she had a hemorrhagic stroke or not, and they stopped her estrogen. When they ruled out a stroke for her, they started on Coumadin 3 a day, and lo and behold, 3 a day was too much for her. She jumped up by day 4 to 2.8. We should have known by day 4, her trajectory was such that she was going to run into trouble, and lo and behold, she did. If we'd given her less on day 4, we probably wouldn't have gone up to 4.1 or 4.4. And so important for us to step back and look at that. Here's a third case, 60-year-old female with a long-term history of AFib and other cardiovascular and DVT history. She's on dialysis. She starts on antibiotics, Cipro, and her INR jumped up high because she started an antibiotic. This is a classic drug interaction we see pretty frequently. Her INR comes in very high, so she gets some vitamin K as an antidote. She gets even more vitamin K because it keeps going up, and she needs to go to cardiac cath. And she gets clopidogrel because we're thinking she may have had a heart attack, and it comes right down. But the problem is that we restart her Coumadin, and we see on day 4, by day 5, it's jumped up to 1.8, so we back off to give her none. Day 6, she's up to 1.9, didn't have gone that much, so we give her 3 again. And we keep looking at her. She probably needs less than 2 milligrams a day. But we also will see that, unfortunately, the first week or so, the vitamin K we gave her is going to blunt her effect for a few days as well. And so once you give patients vitamin K, particularly big doses, then it makes it even harder to dose Coumadin for the next week. Okay, a couple more quick cases before we go on. 84-year-old with AFib and other problems. INR is high, gets vitamin K. Also on interacting drugs of Bactrim and amiodarone, which can also account for the high INR. And we have to reverse that because there's a concern for bleeding in his urine, hematuria. And so he gets vitamin K. At this time, before some of the other newer agents that we now use in place of fresh frozen plasma, we'll talk more about our alternatives in a minute called Kcentra. But he got the reversal agents as well and red blood cells. INR came down, had to continue the drug, and then he's going to be discharged on a lower dose of warfarin, and we're going to be careful that we don't overshoot that, being aware that because we gave him vitamin K, it's really hard to guide where he's going to land because some of that vitamin K is going to blunt the effect of Coumadin for a few days. Case 5, 71-year-old with AFib, basically admitted with high INR. We give him vitamin K. We hold the dose as INR comes down. We restart Coumadin. And keep in mind that his Coumadin INR levels don't do too much until later in the week, and then they overshoot. Why? Because for the first few days, that vitamin K is still hanging around. It's blunted some of the effect of warfarin on the INR. Okay. So as we look at all of these, and it sort of seems like I've gone through a lot of cases, but you can recognize that as clinicians, it takes a while to get the rhythm of how Coumadin works. You can get out of the INR range a lot, and that's problematic. And so we often have to overlap heparin or low molecular weight heparin when somebody's below their INR goal. Our dosing is variable. We'll start with 5 a day on many patients, but if they're older or interacting drugs, typically we'll look at lower doses of 2 or 3 milligrams. And we thought maybe a decade ago some of the newer available genetic testings at that time would help, but clinically we don't do that, and no authoritative body recommends some of these genetic tests, because if you just monitor the response to the INR, you can tell what's going on for patients. All right, so it's pretty clear that with Coumadin, it's problematic to use, and so a lot of us in clinical practice in the last decade have been very happy to see some alternatives to oral warfarin available. And these groups of drugs are called the novel oral anticoagulants. Sometimes they're also referred to as the direct oral anticoagulants. So you'll hear the term sometimes term of NOAC or DOAC, depending on where you're practicing. And for the most part, for many patients, they've largely replaced warfarin, and you can see why, how troublesome warfarin was for us. But also, we'll see that we still use warfarin because still, even in this day and age, these newer agents are expensive and may not be covered by insurance, and or the patient has an indication for which we don't have great data for these agents yet. So things are evolving in practice. But expect that these agents are largely replacing a lot of the older warfarin or Coumadin. So let's compare a few of these agents. And really the three I want you to look at and really focus in on two. And the last one on this slide, edoxaban, at least clinically in practice yet, at least in my practice area, is not all that commonly used in practice. For the most part, the two agents we use most often, at least in our region area as of late 2018, are rivaroxaban and apixaban. We do use dabigatran to some degree. If you remember, dabigatran works a little differently than the others do. And edoxaban has a potential role maybe in the future, but hasn't really gotten the market share that rivaroxaban or apixaban have. So for atrial fibrillation and stroke prevention, for folks who don't have a mechanical valve, these are routinely used in place of warfarin. And as long as insurance covers it, we'll see most patients in this day and age likely on rivaroxaban or apixaban or maybe dabigatran. We also can use any of these agents for treatment for somebody who has a deep vein thrombosis or a pulmonary embolism. If we're looking at more extended venothromboembolic event treatment, particularly after orthopedic surgery, again, you can use dabigatran, rivaroxaban, or apixaban. But more commonly in orthopedic surgery, I think the data is really limited to apixaban or rivaroxaban. And so there are a number of different indications for these oral alternatives to Coumadin, and in fact, I think we see these agents largely replacing warfarin for most of these indications where they're checked here. Let's first look at dabigatran. Dabigatran was sort of the first out of the loop here, and these are direct thrombin inhibitors, or it is a direct thrombin inhibitor. The rivaroxaban, apixaban, and edoxaban are comparing these agents. Just keep in mind that dabigatran is a direct thrombin inhibitor, where the rest of them are 10A inhibitors. And the impact on coagulation and the rest of the factors here are less important at this juncture for you to kind of spend a lot of time with. You might have to pay attention to a couple of drug interactions. They're often, the dose is specific, particularly for rivaroxaban and apixaban, might vary with renal function. The dose varies with indication for use. And so you, with patients' age for some of them, with patients' weight for some of them. And so the dosing gets a little tricky with these agents. But if you open up a drug monograph, as long as you got the right indication, you weigh the risk and the benefit of anticoagulation versus not in the patient in front of you, you can find the right appropriate dose for this patient in common drug reference compendium. There are also, you'll find in those compendium when you're converting somebody either to or from dabigatran to or from another anticoagulant. There are specific guidelines on how to do that based on the half-life and duration of action of both the agent you're changing from and the half-life and the onset of action for the agent you're shifting to. So there are 4 sets of slides here. Don't get into the specifics of these, but just recognize that there's a lot of detail that you need to pay attention to in clinical practice when you're using these drugs and converting from one anticoagulant to another. And this is most often done in an acute care setting. So here's the table for dabigatran. Here's the conversion table for rivaroxaban. Here's the table for conversion for apixaban. And finally, the conversion table for edoxaban. Again, with all of these, just know that there are specific guidelines for converting from one agent to another, and that's very much related to the onset and duration and half-lives of each of the agents involved. There will be times in your practice where you need to reverse anticoagulation in a patient who's been anticoagulated. And so what you really need to do is to be very clear in your setting and in your practice to determine, does this anticoagulation need to be reversed? And the circumstances where that might be the case is serious bleeds or a patient who needs emergency surgery. And then you look at how to reverse that. Sometimes it's just, do I lower the dose or do I stop the drug and let the drug sort of wean away? Is there a problem if I stop anticoagulation? Does the patient have a very high risk for a clot and a relatively low risk for bleeding? Maybe I don't want to reverse it. Maybe I just want to give a little less anticoagulation, or maybe I want to switch to an agent that is a shorter duration of action that I can then turn on and off more readily. So sometimes, for example, somebody's going in for an elective procedure, we may stop their Coumadin and put them on Lovenox or heparin drip, where we have a little better control over when we start and stop their anticoagulation, so that if they're going into surgery, we only avoid anticoagulation in the window of time immediately before surgery until immediately after, and evaluate their bleeding risk after surgery. If the surgeon cut a lot of vessels and there's a risk for serious bleeding after that, then as a clinician, you need to be aware, hey, the surgeon thought this surgery, he nicked a lot of vessels in surgery. I want to be really careful and when I restart anticoagulation and do so carefully because I'm risk for bleeding, post-surgical bleeding into that surgical site. So there is sometimes when you need to reverse things emergently, we have antidotes. The antidote for heparin, a low molecular weight heparin, is protamine. Don't use it all that often, but can use it. We have for warfarin, and we'll talk about this in a minute, we have vitamin K, which takes a day or two to work. We can give it orally. We can give it intravenously, although there are hypersensitivity risks for IV use. And you could give it subcutaneously. I think the data in the last decade has said subQ isn't really all that effective. We can also give fresh frozen plasma, a blood product. In this day and age, we largely have replaced that in more serious cases with Kcentra, and I'll talk about what that product is. It's a 4 clotting factor blood product. For the NOACs or the DOACs, there are specific reversal agents that have just been or recently been approved on the market. For dabigatran, there is Praxabind that's been around for a couple of years now. It's an antibody that binds dabigatran. And when this was available as the only NOAC that had a reversal agent, you found more patients going to dabigatran. Just since early 2018, we now have on the market Andexta. And its availability is rolling out across the country. It's becoming more available as of the fall of 2018. All of these, these reversal agents are expensive. They're in the range of $3,000 to $5,000 to reverse someone. But if someone's bleeding and you need to reverse them, we just do it. We don't focus on the money. We just recognize this is the right thing to do, and we do it. But there's certain protocols that healthcare systems are looking at about who is a candidate and who is not a candidate for anticoagulation reversal. And because these agents both might have hypersensitivity reactions associated with them
and are associated with a high cost, many healthcare settings are putting gatekeepers in, usually gatekeepers related to a hematologist, for example, or somebody from a particular specialty service in the hospital on call to evaluate how to reverse anticoagulation.
Here's a slide that compares some of the newer reversal agents for the novel oral anticoagulant therapies. And I think that it's not necessarily critical at this point that you have a familiarity with the specifics of these agents. You can always find a reference that will help you or talk with the appropriate person at your institution. But to recognize that there are reversal agents for the novel anticoagulants, oral anticoagulants. And so here's some specifics that were published in the CHEST guideline that was published in later 2018 related to treatment of AFib. And we'll see this slide one more time later in the anticoag guideline section. And again, another thing that we'll see later on in the guidelines section is the decision of how to reverse, or what the thinking goes in to reversal of anticoagulation. And so if there's bleeding, you want to assess minor versus major bleeding. And if it's minor bleeding, we often, as we alluded to, just hold the anticoagulant. For moderate bleeding, we may have some degree of reversal, might be a blood product, for example, or with warfarin, give vitamin K. And then when it's severe or life-threatening bleeding, that's when we get to the specific antidotes and maybe Kcentra or something like that as a consideration as well. So I happen to work at a hospital that is one of the partners, Mass General hospitals in the Northeast. And here was, as of late 2017, their algorithm for reversing warfarin. And you can see that if it was a life-threatening bleed, they looked at rapid reversal, typically with vitamin K, and either fresh frozen plasma or the prothrombin complex concentrate, Kcentra, we'll talk about in a minute. Don't focus on the details of this, but just recognize that this was the case. If it wasn't life-threatening, but their INR was over 9, then they recommend a low dose of vitamin K. And if it's not greater than 9 and they're not bleeding, just stop the drug, stop the warfarin, and maybe give a very low dose of oral vitamin K, if at all. For folks who have a problem with needing to reverse a NOAC or a DOAC, their guidelines are also listed here. And depending on if it was a mild, a moderate, or severe bleed, if they were a candidate for the reversal agent. And really only in life-threatening severe bleeding did they recommend the reversal agent for dabigatran. And I haven't had access at the time of this recording for what these newer guidelines are, but I'm going to guess they've been updated in 2018 to include a 10A inhibitor and dextra for serious bleeds if they were on a 10A inhibitor. So what is Kcentra? Kcentra is a 4-factor prothrombin concentrate that is a little more specific than the fresh frozen plasma is as a reversal agent for severe anticoagulation, particularly as it relates to warfarin or Coumadin, or patients who have otherwise been anticoagulated and there's not a specific antidote. And there are guidelines for how this is used and who sort of shepherds its use in an acute care setting. There are lots of guidelines on dosing about who gets what dose, and it's dosed based on the INR and the risk for bleeding and the weight of the patient. And so all these dosing considerations are beyond the scope of what I think we want to focus on today, but I think you need to be aware that there's such a regimen in place. Okay, the final area that we're going to talk about before we fly through some of the guidelines nationally and internationally for some of these agents are the fibrinolytics. And these are agents that actually work to decay existing fibrin. They will bust a clot, or the older term lay people would use are the clot-busting drugs. The fibrinolytics had been used pretty commonly maybe 2 decades ago when they first became available for folks who had an MI or a heart attack coming into the hospital before we had available cardiac catheterization labs in most hospitals
within a 30-mile radius of where patients live, or most patients live. But we will see these used still for heart attacks in patients who are in rural areas where there would be a delay in getting a patient to a cardiac cath lab. We also use these agents for patients who've had an evolving thromboembolic stroke. We'll talk about that a bit here, much more in neurology, and in low doses or targeted administered doses for other indications as well. What these drugs do is they dissolve an existing clot by promoting the digestion of fibrin. Because they do that, there is a much higher risk for bleeding as well as more effective clot destruction or decay with these agents as well. So they are both life-threatening and life-saving. You've just upped the ante quite a bit when one of these agents is chosen. They're typically only going to be given in the emergency room or in a setting, at least at their full dose, in a setting where there might be guided imagery, interventional radiology suite, for example, or someplace where there's a lot of monitoring and ability to monitor a patient who's on these drugs. Really the only agent we see used in clinical practice in this day and age is either alteplase, known as TPA, or a version of alteplase, which is tenecteplase. And really that's the only one that's on the market in the U.S. now. And we'll use them also to treat other thromboembolic events like a pulmonary embolism or DVT or a peripheral artery occlusion. But when we use them in those individual settings, it's limited based on the hospital's protocol and only given usually by an interventional radiologist in the interventional radiology suite, where they're able to administer that agent, with imaging directly where the clot is and nowhere else. And so it's pretty limited in its role, and usually its use for these localized areas is limited to a more tertiary care setting, at least in my limited experience. So these agents will work by interfering with the conversion of plasminogen to plasmin. Their indications are for an evolving MI, really second-line therapy, or first line is get them to the cath lab, or for a massive pulmonary embolism, or for other thrombotic events. But there are lots of contraindications to use. We'll get more specific about that in a minute, but patients with recent surgery, recent bleeding, a recent CVA that is not thromboembolic, we got to really worry about that. If they've had trauma, if they have uncontrolled hypertension, those are some of the major ones. We'll talk more specifically in a minute. Adverse effects are always going to be bleeding. We're going to worry very much about bleeding with these agents. Also, you might see allergic reactions, hypertension, other things as well. And the dose you don't need to really focus on, but the dose is very specific for indication. Are we using it for an MI? Are we using it for a thromboembolic stroke? Are we using it for a pulmonary embolism? Are we using it to clear a catheterization in a renal patient who has an occluded catheter? All of those are very different dosing and very different regimens. When we give a patient alteplase, you have to think about not only did you decrease the thrombus, which is in the lighter pink here in the upper slide, and you can see how it went down, but you also decrease or open up any hemostatic plug that may already exist, and that is a risk for bleeding and hemorrhage. And so these are really risky agents to use, and you have to have really a compelling reason or indication to give them before we just treat any patient with these drugs. So there are certain doses here. Here are some dosing for acute coronary syndromes, dosing for ischemic cerebrovascular events, and or cath occlusion, much different. And we need to be very clear about ruling out bleeding when we use each of these. More discussion on each of these agents when you get to cardiology or neurology. There are contraindications of fibrinolytics, which you alluded to. They're listed here. There are relatives versus absolute contraindications. But just stop, and as you look at all of these, you don't need to memorize these, but look at them and you'll see there's a theme to these. Folks who are going to be at high risk for bleeding episodes are going to be the major concern for us. Folks with very high blood pressures, folks who've had aneurysms or any intracranial bleeding ever. You're going to worry about anybody who's had other severe bleeding, peptic ulcer disease, and the like, and you weigh the risk versus the benefit of that. One other issue before we sort of go into a quick fly-through of what some of the national standards are here's a national standard for the Joint Commission on Accreditation of Hospitals, and this has been in place for the last 5 or 6 years, and this is the 2018 National Patient Safety Goals. And you don't need to be aware of this other than to know that the accrediting body that allows hospitals to get accreditation and receive Medicare and Medicaid funding, hospitals have to pay attention to when they use anticoagulants and antiplatelets, particularly anticoagulants. And so this a governing body, this accreditation body who comes in and spot checks hospitals unannounced, pays a big deal to this. And if you haven't set into place being very careful about the risks and the benefits of anticoagulation, this is an organization that says if the hospital hasn't done a good job at monitoring how their patients are cared for with anticoagulation, we could lose and risk our Medicare and Medicaid funding. That's a big deal.
One of the areas in pharmacotherapy that's really, in a sense, exploding in practice is the review of genetics in various practice of medicine, and certainly in cardiovascular medicine, we see it particularly related to antithrombotics. We see genetic variation, particularly with 2 agents that are antithrombotics, the antiplatelet clopidogrel and the anticoagulant warfarin. And so let's sort of spend a little time looking through some of the bigger issues with genetic variation in these 2 agents. But I will say that at least in the practice settings I've been in, we've not routinely done genetic testing yet for use of these 2 agents. I think of the 2, I think you're more likely to see in some larger centers, or as time goes on over time, maybe more commonly for clopidogrel. I think the jury is somewhat out for the utility of doing genetic testing for warfarin, only because if you give a small dose of warfarin and you look at the trend in the INR, that's actually a way to influence what the genetic variation is. At the very least, as a clinician, you need to recognize that not all patients on these 2 agents are going to respond in the same way, and so there are considerations that need to be made. So let's first talk about clopidogrel a bit. Clopidogrel, as we alluded to and will continue to allude to, is a prodrug. It's chemically converted to its active metabolite, and that active metabolite is related to cytochrome P450 2C19. And that particular enzyme is genetically influenced. So if someone has a deficiency in 2C19, it's conceivable that they won't convert clopidogrel to its active drug, and so it won't work as an antiplatelet. And so those folks who cannot metabolize clopidogrel, who have a deficiency of cytochrome P450 2C19, are at greater risks for major coronary events, particularly when we're using these agents, antiplatelet drugs, in a patient who's high risk for a clot, including patients, for example, who've had a coronary stent. So that's going to be a concern. The other concern is we may have someone who actually is a rapid or a very rapid metabolizer of cytochrome P450 2C19, and it's conceivable that those patients may actually be at a higher risk for bleeding because they may have an excessive conversion of clopidogrel to its active metabolite, although the jury is somewhat out on that. The genetic testing that could be done and is done in some settings, I'll tell you I don't have any experience with this in our practice area, but would be to test for alleles related to the cytochrome P450 2C19. And the majority of patients have normal function for 2C19, and this slide sort of demonstrates which alleles are associated with reduced or no function of cytochrome P450 2C19. So as we see folks with their genotype of, so how that presents phenotypically varies. And so among Northern European descent, for example, ultrametabolizers or rapid metabolizers represent about 30 or a third of the population. Normal metabolizers, a little more than a third. And poor metabolizers, actually quite low percent. And for African Americans, that's similar but not identical. What we see, though, in East Asian populations is that many of those individuals have a deficiency of or a diminished ability to metabolize clopidogrel 2C19. And so if you're not doing genotypic or phenotypic testing in this population with East Asian, there might be a consideration for, hey, this might be a higher potential risk for patients who don't respond as well to clopidogrel. Maybe I'll consider a different antiplatelet in those patients who have a stent, for example. So the genetic influence in summary of this is that for those folks who are intermediate or normal metabolizers versus intermediate metabolizers versus normal metabolizers, those folks have a slightly higher risk for major adverse cardiac events. That's an MI, that's a thromboembolic event of some kind. And folks who are poor metabolizers compared to normal metabolizers have a considerably higher risk for major adverse coronary events. So that becomes a concern for patients who've had, particularly who've had a stent, and the risk for a stent thrombosis in those patients even higher. So really a consideration in folks who are coming out of the cath lab with a stent and which antiplatelet is chosen. The difficulty is that when you're going to a different agent than clopidogrel, the other two agents have higher bleeding risks associated with them, even though they may be more therapeutically effective. And so this genetic influence has to be assessed. That's usually done by the cardiology team who's assessing the risk-benefit of the particular antiplatelet regimen in that particular population. The second genetic influence I'd like to sort of refer to, and not spend too much time with this, is warfarin. And warfarin has a couple of points where genetic variation can influence either receptor site, and that's at the VKORC1 related gene function. And the second has to do with the metabolism in the cytochrome P450 enzyme systems. And that includes both a cytochrome P450 4F2 and also the metabolism of warfarin is affected by cytochrome P450 2C9. And so those are variations genetically, and those are going to mean that someone's going to have a different sensitivity to the dose of warfarin we give them. So for 2C1, for example, cytochrome P450 2C9 enzymatic differences, we see variations among populations with decreased function in metabolism in people of Northern European descent, whereas we'll also see it in African Americans, but in those alleles that or variants that are not as commonly tested for in standard genetic testing. So the alleles that are normally tested for in or widespread testing, if testing is done genetically for warfarin, are the alleles 1, 2, and 3. But if you've got someone of African American descent, particularly you want to be testing for 6, 8, and 11, and because 5, 6, 8, and 11, because those are seen more commonly in that population. The translation of those variation alleles sometimes means that the warfarin dose might need a significant reduction because they have less ability to metabolize warfarin. In addition to the metabolism of warfarin, the variation in the VKORC1 gene status affects the sensitivity of warfarin, and we see a lot of variation across populations, particularly in this case again in East Asians. And so we see a concern with this particular gene. And for the cytochrome P450 variations. We see differences across in prevalence across populations with variation. And so the bottom line, I think, as clinicians, is even if you're not doing genetic testing for warfarin, there is a genetic variation that's widespread and significant for warfarin. And anybody who's been in practice and has used warfarin, which we've used for decades, has realized how difficult it is to titrate that dose and how much variation there is from patient to patient. And so we are very careful about monitoring INRs carefully with dosing, looking at trends in INRs if we're not doing genetic testing. And it's one of the reasons why the guidelines for AFib in most patients who don't have a valve or a mechanical valve problem are recommending, in fact, that patients use the NOACs first line as opposed to warfarin, because warfarin is just so difficult to manage. The other issue is that all this genetic variation, compounded by drug interactions that affect these variables, mean that the patient could be above or below therapeutic range for a longer period of time. And when a patient is out of therapeutic INR range, our goal range, below range, that's a risk for a clot. Above range, that's a risk for a bleed. Render warfarin really a difficult drug to manage.
Okay, let's go through some supplemental content as of late 2023. And again, this is based on a summary set of guidelines from the American Heart Association and the American College of Cardiology. If you remember, the classic guidelines are stratified by both the strength of the recommendation and the level of evidence that support it. So the strongest recommendations around antiplatelets look at the role for using antiplatelets in patients who have chronic coronary disease. And if they're not a candidate for an anticoagulant, then low-dose aspirin is a strong recommendation. They also look at the role of dual antiplatelet therapy in patients who have had percutaneous interventional therapy, PCI, and in those individuals, dual antiplatelets are recommended for a period of 6 months, followed by a single antiplatelet therapy to reduce major events. We're weighing that against bleeding risk versus future clot risk. The remaining of the recommendations are more variable in the lengths of strengths. And beyond the first recommendation here of patients with chronic coronary disease, where you'd make the decision for aspirin without an indication, if they don't have an indication for an oral anticoagulant, the remainder of these are likely going to be in the realm or decision-making role for the cardiology team. If that happens to be where you are, then you'll become more versed in that and whatever the guidelines are by the time you get to that role. But suffice it to say that the role of antiplatelets and anticoagulants in cardiology, particularly patients who've had an intervention, they've gone for PCI or they've gone to the cath lab for some other reason, those individuals, particularly if they've had a stent or not a stent, those decisions have evolved over time, and you'll see many patients where the cardiology team is determining the agent or agents, either a single or dual antiplatelets on board for them for whatever periods of time, depending in part on was it a drug-eluting stent or not, which for most patients it would be a drug-eluting stent these days, and then the duration of therapy of the dual antiplatelet versus a single antiplatelet might be in the realm of would be in the realm of the cardiologist to decide, but might be determined based on other comorbid states. It might be based on their bleeding risk. It might be based on the number of vessels and the number of stents that were involved, and even the location of that. So as you look through the remaining set of these guidelines in this block, again, keep in mind most of these are in the realm of the cardiology service to be aware of, and you should have familiarity with the general themes here, but recognize that the decisions for single versus dual antiplatelets, which agents, for how long, really is determined again by cardiology. You can see more recommendations for antiplatelet therapy in the absence of anticoagulants, but in this slide, particularly who is not recommended for that, particularly in patients who've had a history of a TIA or intracranial hemorrhage, how we're avoiding certain other sort of risks of which would increase the risk for bleeding, where more harm would likely be seen with very little benefit. There are also guidelines for patients who might be a candidate for both antiplatelets and anticoagulants, particularly the DOACs. And in this case, we're looking at pretty high risk patients who are at risk for undergoing some major risks, who have undergone PCI, and they require both anticoagulants, typically DOACs, the direct acting oral anticoagulants, and then the role of when does dual antiplatelet versus antiplatelet alone therapy be considered. So you can walk through these and recognize that there's varying levels of evidence depending on the particular scenario the patient has. Again, all of these are pretty much under the realm of cardiology. At the bottom, you'll see that there is some evidence to say that the role of a PPI, proton pump inhibitor, might be considered in patients who are on dual antiplatelet therapy to lower the risk for GI bleed. That is not the strongest level of evidence, nor is it the strongest of recommendations, but it's a consideration. And in practice, we see that done fairly frequently in patients who are high risk for GI bleed. This graphic will outline who is a candidate for antiplatelet or dual antiplatelet therapy with or without oral anticoagulation on board, depending on what their risk factors are. Have they had PCI or not? Do they have acute coronary syndromes? What's that history for them? And so are they candidates for aspirin alone, dual antiplatelet therapy? If so, for how long? How's the level of evidence for each of those? And keep in mind that the coloring scheme here is consistent with the strength of the recommendations that have been made, where green is the strongest recommendation, and yellow less strong, orange even less so. Other issues you'll see here as well, and you've seen these slides before, relate to the risk in pregnancy and lactation. And here, let's look primarily on the right-hand column, where we're looking at the DOACs are considered contraindicated in pregnancy and in lactation. And that's pretty much true for warfarin as well, although that's not listed on this in this document or in these slide sets. Finally, the next sets of slides refer to medical therapies in the relief of angina. And so in acute coronary syndromes, we often see that patients would be a candidate for a beta blocker, a calcium channel blocker, or a long-acting nitrate. And they pretty much in these set of guidelines consider any of those as reasonable, strong evidence recommendations here. And then in item number 2, for patients who remain symptomatic after an initial treatment in step 1, they would recommend adding a drug from a different therapeutic class as a strong recommendation. The remaining recommendations are would probably be in the domain of cardiology service to look at where each of these modalities might fit. And the recommendations for revascularization, the goals of revascularization, and the goals for, in the next slide, patients who might be candidates for a CABG or something. Each of these are, again, pretty much, we include them here, but they're in the domain of the cardiologist and might be more covered in your general medicine block rather than here in therapeutics. Again, who is candidate for PCI versus a CABG? They outline some recommendations here. They also look at in invasive coronary function testing definitions and the pharmacotherapy that might be considered in individuals who have varying types or etiologies for their angina or their concerns for how they present and what the pathology is involved, and then which agents might have more or less benefit in each of those cases. And then finally, again, the list of medications with safety in pregnancy and lactation. And again, you can sort of see here the issues for, on the right-hand side at the top, the role for vasodilators like isosorbide, dinitrate, or nitroglycerin have a less strong data set for them. So there's limited data on risk or benefit for many of these agents that might be considered. Same is true on the left-hand side when you're looking at managing angina. And so in angina, in women who are pregnant, for example, it could be probably metoprolol is considered the safer choice, where you'll see the calcium channel blockers, there's limited data, and nitroglycerin is limited data. So again, in women of childbearing age, particularly in pregnancy or who could become pregnant, metoprolol is probably your best bet. Finally, again, here's the list of drugs which we would not necessarily expect you know doses or have familiarity with doses in this block, but again, by the time you get to clinical, we would have an expectation that when you get on clinical rotations, you're going to become familiar with what typical doses might be for these more common agents.